a este coloquio, a esta reunión. Y es que la atención centrada en el paciente, creo que Colombia, sobre todo, se olvidó en los últimos 30 años. ¿Por qué razón? No quiero mirar las razones por qué nos olvidamos de esa falta de humanización o falta de atención centrada en el paciente. Pero yo tengo dos anécdotas que contar que me enseñaron a mí. Yo he atendido más de 3 millones de personas con cáncer en estos más de 20 años. Ya no las trato, desafortunadamente. Y yo me acuerdo una vez que llegué a Riohacha, por allá en el año 80 y pico, yo tenía 20 y tantos años, ya era médico, y llegué al consultorio y me senté y llegó una señora y me miró, una matrona de esas guajiras, y me miró así, se quedó como estupefacta y me miró y me dijo: niño, ¿y dónde está el médico? Y ya yo era médico. Hice dos cosas. Al otro día me dejé crecer el bigote para parecerme mayor, pero entendí, y después ella me lo explicó, que el médico tiene que tener una actitud de médico. No puede ser cualquier persona, tiene que tener una actitud de médico, y ahora voy a explicar por qué. Y años después, como a los 3 o 4 años, me fui para España a formarme, y una vez atendí a 2 gemelos de unos 20 y tantos años, con un linfoma los dos, con HIV los dos, y la mamá llegó desesperada y me insultó, y yo le insulté también. Y después esa señora me invitó a tomarme un café, yo salí a tomarme el café, me dio una lección, porque me explicó todo lo que le había pasado a ella y todo lo que le había pasado a sus hijos gemelos, y yo dije: carajo, no tuve compasión. Y entendí que había que tener compasión. Entonces, y eso me ha dado también para atender más de 3 millones de personas. La clínica no sé cuántos ha atendido, pero yo he atendido más de 3. Y créanme que si no manejamos esto de la humanización, nunca seremos humanos. Cuando un paciente se enferma, pónganse enfermos cualquiera, cuando alguien se enferma, tiene un problema emocional, tiene un problema social, tiene un problema mental e inclusive un problema de comunidad, porque su entorno se altera totalmente. Y eso produce un cambio de emociones, y ese cambio de emociones le destruye el ego, le destruye el yo al paciente. Entonces nosotros que estamos en la otra película, tratando de sanarlo, lo que tenemos es que ayudar. Y aquí viene algo de la conferencia: hay que tener sentido común. ¿Y qué es sentido común? Es esa capacidad que tiene el ser humano de entender razonablemente. Miren ustedes, capacidad para entender o comprender razonablemente, para luego, cuando ya comprendiste, tomar decisiones pragmáticas, prudentes, coherentes, simples, sencillas, con sabiduría. Eso es lo que tiene que hacer todo el gremio que está en la salud. Si no tenemos ese sentido común que se amarra a algo, y se lo puedo decir que es la vocación. Yo cuando fui profesor universitario, ya hace muchos años, le decía a cada uno: si no eres humano, si no tienes vocación, no estudies esto. ¿Pero qué significa la vocación? Es algo que te nace de aquí y de aquí. Tu deseo, tu pasión. Si eso se pierde o si no lo tienes, no podemos estar en el sector salud. Y no hablo del médico, hablo de la enfermera, hablo de la auxiliar, hablo del administrativo. Debería haber un examen de sentido común y debería haber un examen de vocación. Entonces, ¿qué pasa después cuando tenemos la vocación y tenemos ese sentido común? Tenemos que expresarnos en la comunicación, y es lo que llamamos hoy la comunicación asertiva. Quise hacer esa pequeña introducción para presentar al doctor Gregory Michael, ilustre, asesor estratégico del Plaintree International del Hospital Israelita Albert Einstein. El doctor es un experto internacional en comunicación en salud, conocido y reconocido por aplicar el diseño centrado en el ser humano y en el sentido común radical. Fundó el Human Understanding Instituto y creó el enfoque One Big Dot, el NRC Health. También fundó Patient Window y ha sido docente en la Universidad de Yale y la Universidad de Connecticut. Ha liderado reformas educativas, desarrollando herramientas globales para enseñar comunicación clínica. Todo esto lo ha llevado a aumentar la experiencia de las clínicas, la calidad, la seguridad y, por supuesto, la equidad. Yo creo que le vamos a dar la palabra al doctor para que él mismo nos explique toda esa famosa y, por supuesto, disertar sobre esa experiencia tan bonita que es la humanización a nivel mundial. Bienvenido, welcome to Colombia, to Cartagena. I hope that you fun and enjoy and rest and a little working. Okay.
Muchas gracias. Thank you. Gracias and buenas tardes todos. Okay, where's the clicker? I am very, very happy to be with all of you today. Thank you for coming, and thanks to OES for inviting me. We're going to talk about something that I call the radical common sense of humanizing care. You'll understand why I'm calling it radical common sense instead of just common sense in a few minutes. We're going to do a lot today. Okay, we're going to talk about all of these things, starting with what does it mean to understand what matters to people, and give you a couple of examples. Talk about what are the threats to common sense. I'm going to tell you right now that I will feel embarrassed because I'm going to tell you things you already know. I'm going to tell you things that everybody should already know, but they're not happening. So why aren't they happening? What are the threats to the common sense that we all know? Talk about what it means to reinforce the humanity of healthcare, how we think about person-centered care differently, and then talk about what good, effective, intentional communication looks like. Talk about really, really understanding what matters, and then an idea that I'd like to share with you that I call one big dot, and you'll understand why, and then we'll wrap it up. Okay? Sound good? Okay. So let's start. I don't have any conflicts. Are going to be polls. You have to use your phone. Okay? So if you can take a QR code thing of that, we will get started. I'll give you a moment to do that. Should be big enough, right? Okay. Thumbs up if it worked. Okay. Everybody good? Okay, here we go. When you hear someone say they love their doctor or their nurse or some other member of the healthcare team, what do they say? What do you hear them say? And what a lot of people put is listen. That's why that was the first thing there. I have to tell you, I've been asking this question for like 35 years, okay? I asked it in Norway last year. I was doing a keynote at a conference, and they said, we would never say we love our doctor. It's like, okay, but what if you really liked your doctor? What if you thought your doctor was really good? They said, okay, that we could do. So, trust. Coming up big, Peter, trust. Listen, care. And some are in English and Spanish. You got escuchar and listen. Respect, you can see. Gratitude. Please take a picture of this so one can remember. This is what we're looking for. This is what everybody's looking for. I told you, I've been asking this question for 35 years. I got the same answers every time. Sometimes they're in different languages, but they're all the same. We know what we're looking for. Are we getting it? How many of you feel like all of this has happened in your encounters with healthcare team, with health professionals? You have relationships with your health professionals? I see one hand. Okay, I don't think it's just a translation problem. 3 hands. Okay, it's not happening enough, right? It's just human connection, and it's not happening. This is my mother. This picture is from almost 10 years ago, probably. My mom had pancreatic cancer. You can see there's a little port here on her for chemo. And the first time we went to the oncologist, she had a really good, my mother, I made sure she went to the best doctor at the best place, right? But it was what I would call a typical oncologist conversation. It went like this. Okay, Kathleen, we could do the 2-drug chemo regimen, and here are all the bad things that'll happen. Or we could do the 3-drug chemo regimen, and here are all the bad things that'll happen. What one do you want to do? And to her credit, my mother said, we'll get back to you. And because I was in the room, I said, would you like to know her goals of care before we talk about the plan of care? And I said it very respectfully, very politely, and to her credit, the oncologist, who is excellent, said, oh my gosh, I'm so sorry. Could we start over? My wheels were turning so fast that I was kind of forgetting that part. And it is the most important thing, is to get to know what matters to you. They did start over. My mother ended up picking the 2-drug chemo regimen. And these 2 5-foot-tall women became friends over the course of the next 18 months of my mother's life. And the reason is because by finding out my mother's goal of care, which was to live, not just to stay alive a statistically significantly longer number of single-digit days, but to live, they came up with a plan where my mom did what they called chemo vacations. Okay, so she would do chemo for a while, and then she'd go to Cape Cod, off the coast of Massachusetts. She'd do chemo for a while, and she'd go to Florida. She'd do chemo for a while, and then she'd go do something else that she wanted to do with my dad. Okay, so that's how she lived the rest of her life, and it was a good rest of her life. Because of that one conversation, because she started over. Now, I wonder how often somebody's going to have their kid in the room who has been working in healthcare for 40 years to have the confidence to ask that question, right? What happens when you're there by yourself, right? That's why we have to work so hard on what seems simple, okay? Oops. Okay. This is a good example. What I just told you is a good example of how people's perspectives influence care. If you look at your patient like she's a data point, you're not going to have a conversation about goals. If you look at your patient like she's a clinical case or a type or a segment or a problem, it's going to be a different kind of conversation than if you look at your patient like a unique human being. Right? Does this make sense? And these 3 perspectives are all happening all the time. It's just a matter of which one ends up in the encounter that drives the way that the experience and the delivery of care comes through. Now, I am not a big Twitter person or X person. I don't post things. But I love this tweet. This is from several years ago. This is a mom who has a child with a pretty serious chronic illness, And what I love about it is you can literally hear her tone of voice by reading this, this tweet, right? Says it would be relevant to me if you join me in what I'm doing instead of trying to engage me in what you're doing, right? This is how patients feel, right? Why aren't you paying attention to what I'm trying to do, to my goals, right? And part of the reason is that we forget that most of patients' lives happens outside of the care setting. My friend Allie here is an unusual patient. She goes to the doctor every single week of the year, 52 weeks a year, for a 15-minute visit. Now, if you do the math and you say 15 times 52 minutes divided by all the minutes she's awake during the year, that accounts for 0.2% of her life is in front of a doctor. That means 99.8% of her life is in a healthcare setting, right? So why, when she's in the clinic office, are we only seeing her as somebody who has diabetes, say? Okay? It's because that's all we see. It goes back to the perspective idea. Okay? So we have to remember we're dealing with entire human beings who have lives that are happening outside of the hospital room or the exam room. So it all makes sense, right? I hope. So the way I think about this, and Peter did it was fun, but it was also really important, this point about the dance, right? What I'm talking about here, meetings between experts, is the dance. No one should question that the clinical care team are the experts on clinical care. That's why people went to medical school and nursing school and all the other schools, right? They are experts on care. But there is also no question that patients are experts on their own lives, right? And care is only going to work well if they're taking advantage of each other's expertise in a good way, if they're paying attention and respecting each other's expertise. That's the dance. And it's not as hard as salsa. Okay? So, again, I feel a little funny telling you things you already know. Everything I told you, you go, yeah, of course. Right? That should make sense to everybody. So actually, before I go on, does what I've been telling you make sense to you? Does this sound real? Does it sound true? Yes? Okay, CC. Okay, so why isn't it happening? It's not happening. We had 3 hands go up when I asked, are you getting those things that we all said we want? Right? Why isn't it happening? Here's one reason. There are lots of threats to common sense, but this one is important, and this story is not about my mother, it's about my father. So there's a holiday in the United States called Thanksgiving. That's the last Thursday or the 4th Thursday of every November. People eat too much turkey and watch football, American football. And my father came to our house. It used to always be at my parents' house when my mother was alive, and then we took this over for the family. So the whole family is down at our house. It's about an hour away from where my father was living. He comes down, he has a great time. My cousin drives him back to where his place was, and within 5 minutes of being back home, he fell and he broke his pelvis. And so I got the call, I drove up an hour to the emergency room, and I walked into the emergency room, and the young woman at the desk hardly even looked up at me. I don't even think she looked up at me. Kind of just, her head was down, but her eyes went up, kind of. And she said, oh, you must be here to see room number 4. Well, I wasn't there to see room number 4. I was there to see my father. And I resisted the urge to make that a teachable moment for the young woman and just said, I'm here to see Ralph McCool. If he's in room number 4, then yeah, that's where I'm going. I go to room number 4, I walk in, he's with a nurse who says, oh man, I'm so glad you're here. Your dad's been waiting for you, and I don't know how he's doing this. He's got to be in a lot of pain, but he is the coolest guy. He's been making me laugh the whole time. He's been talking about you, and he's just awesome. Room number 4 versus, what a great guy. He's just awesome. Right? 2 different perspectives. One is a problem in a room, and one is a human being who was just awesome, right? Again, this is this routine of, oh, there's another one in room number 4 and another one, right? And then I've got all those other rooms, right? That's routine. That numbs us to being human, and that's not okay. Keep hitting that. Another threat to common sense is this sign. You can probably see at the top, it says caution, cuidado, right? This sign has sharp edges. And then it says, do not touch the edges of this sign. And then at the bottom, it says, oh, also, the bridge is out ahead. Okay? What happens in healthcare is what we see is what's right in front of us, and something is always right in front of us. Always, right? And so common sense can be squashed, it can be pushed down by urgency, and everything is urgent all the time, is what it feels like. So how do we take a breath? How do we make time to remember that we're human beings dealing with other human beings? Right? And the last one that I'll mention is burnout. We've all been talking about and worried about burnout for good reason, right? But if you feel like you can't get your head off the desk, you're going to have a really hard time at doing a great job. And when you have a really hard time doing a great job, you feel even worse, right? So how do we restore our ability to really care? Care for ourselves so we can care for others and about others. Okay? So let's think about these threats to common sense in the context of now, the real world of healthcare now. We'd have all of these new ways, newish ways of performing our work in healthcare. We have teamwork. We have lots of different services. We have more and more technology. AI is coming, and nobody even knows what that means yet, but it's coming, right? And we have multiple care settings, right? Those are all supposed to be good things, right? Should be sunshine, sunsets, beauty, but they don't feel that good for the people that are necessarily dealing with all of these things. They don't feel that good all the time. In fact, they kind of feel overwhelming. And there are even more things, right? So we've got all of the other things that you see here, fragmented care, et cetera. Okay? It's hard. Healthcare is hard these days. And we tend to make it harder than it needs to be. And that's one of the things that we're going to talk about. I've been working with an international group of mostly communication scholars, but they are people that are educators, researchers, doctors, physical therapists, people in different areas of clinical care, all interested in communication. Been working with them on reinforcing the humanity in healthcare, what that means in the real world, okay? We did a consensus statement. It was called the Glasgow Consensus Statement. Published that in the spring of 2024. We published a new article in the World Medical Journal in March of this year, and there's another piece that'll be coming out in a few months. I want to just highlight for you a few elements from this consensus statement because they are very relevant to what we're talking about today. We laid out 3 what we called overarching tasks, okay? Things that are woven throughout all encounters, all episodes of care, all of the time. It's not like you do it, you check a box, and you're done, okay? They should be happening all the time. The first one is to connect as humans, right? Treat every person in the encounter as a unique human and show attention and respect to that person. Does that make sense? The second one is to understand the patient's perspective. This is kind of like the example with my mom, right? What are your goals? What are you trying to achieve? And then to incorporate that knowledge into the care plan. And the last one is to be responsive. Pay attention to what you're seeing and hearing and feeling, right? Tailor what you're saying to the person, to the situation, and pay attention to changes in their tone, their emotion, how they're carrying themselves, which is their demeanor, okay? These are simple human behaviors, okay? These are the things that you all basically said you were looking for, right? When you think about it. These are not that hard. And yet, they're not happening enough. And we feel like it's important to get the word out to leaders like you all over the place to say, please, let's figure out how to do these in the real world, right? And not just with patients, but with each other. We stepped back after we published the consensus statement and we said, oh my gosh, wouldn't it be great if, like, colleagues did these overarching tasks with each other? So we changed the one that said understand the patient's perspective to focus on understanding, but you can see it's the same things. Connect as humans, focus on understanding the other person or the other people, and be responsive to what you're hearing and seeing and feeling. We can do this, right? And wouldn't it be nice? And it's more than nice. It's not about being nice. It's about being effective. This is what will make healthcare effective. This is what will get to what Peter talked about this morning in terms of engendering trust. Front stage, front office, and backstage, back office. Now, Planetree, I've been working with Planetree. I'm proud to be a strategic advisor working with the team there. And we, over the course of the past year or so, worked with a group of people, some of you are in this room, to redefine person-centered care. And the way we defined it is up on the screen. Compassionate, collaborative care that improves outcomes by focusing on what matters to everyone involved in healthcare experiences. Not just patients, okay? Not just patients and family members, but also the healthcare team, okay? Also community members when that's relevant, okay? So another way to look at it is like this, right? Really reinforce these ideas, right? Compassionate collaborative care improves outcomes. Again, it's not to be nice, it's to be effective. Focus on what matters to everyone involved in healthcare experiences. If we're serious about this, if we're focusing on what matters to everybody, we can't just look at patients and families. Okay, we have to pay attention to our care teams, to our health professionals. And so I think the key here is if we want to know this stuff is happening, we got to measure it. assume nothing. You can't assume it's happening. You can't assume it's not happening. You can't assume it's happening a proportion of the time unless you measure it. So we at Planetree have been developing a set of person-centered care indicators, a measure. And again, some of you have helped us with that, and thank you. And so I'm going to just point out one thing and then ask you, again, to pull out your phones and try this, okay? The innovation here is we are asking exactly the same questions of patients and families as we are of people on the care team, okay? So we took that definition of person-centered care, we turned it into measure, four questions, and we're asking patients and families those questions, and we're asking healthcare professionals those questions. So I'm going to ask you to answer as a healthcare professional in whatever your role is. If you're in administration, fine. If you're in clinical care, fine. If you're in any other role, fine, okay? But answer in those ways. And I should really stop hitting the reverse. Okay. Here's the first one. How are the people you work with at connecting with you as a person? Okay? Is your poll still working, or do I need to... Janet, is it working? Yeah? Okay. Just give you a minute to do this. How are the people you work with at connecting with you as a person? That means showing interest, compassion, and respect. Okay. This is very, very interesting to me. This is not bad, right? It's not bad, but it's not good. I'm going to show you some data later that will demonstrate to you that the only thing that matters is when people say excellent. Okay? And the fact that 8% of the people so far are saying excellent means that 92% of the time this isn't happening. Okay, we have work to do. Let's look at the next one. How are your supervisors at paying attention to your goals, your needs, and your preferences? Be honest. How are your supervisors at paying attention to your goals, needs, and preferences? Janet, can you take pictures of these two? %. Excellent. Okay? Mostly good. How are your supervisors at encouraging you to ask questions? I worked in a place when I first got there. It was a big hospital in Connecticut, and I had a senior administrative role, and people were afraid to ask questions when I got there. And it took me 9 months to get them to feel they could trust that it was okay. Okay, 5%. Excellent. And the last question is, how are your supervisors at involving you in decisions that affect you? kind of weighted in the poor and fair, the poor and fair aisle here. But here we're seeing, again, 8% excellent. Okay, work to do. Now think about it. We're asking those same 4 questions of patients and families, not about how did your supervisors do it or your colleagues, but how did we, as the group that's taking care of you, the organization that's taking care of you, do at connecting with you as a person, paying attention to what matters to you, encouraging you to ask questions, involving you in decisions that affect you. Every organization that uses these new person-centered care indicators will get a window into how patients and families and everybody that works in the healthcare organization feel about whether or not they're delivering on the promise of person-centered care. That's a beautiful thing. That's a really important thing, and that's the kind of thing that can help us get beyond those threats to common sense, because we can start, these are all actionable. If people are feeling like they're not involved in decisions that affect them, there are things we can do, right? If they feel they're not involved in, or they're not encouraged to ask questions, there are things we can do, right? So these aren't vague sorts of things, okay? And they're all driven by that definition of person-centered care. Okay, thank you for doing those polls. Okay, let's quickly take a look at what I mean by effective, intentional communication. I want to start with empathy. In the real world, again, I am very, very practical, okay? When we generally hear people talk about empathy, or we read somebody who's written about empathy, we usually see something like it's a shared feeling or experience, right? We asked patients what empathy means to them. And what we found is just acknowledgement. That they said something is hard, or something is great, or they have an emotion about something. Just acknowledging that they felt was empathy. They said, you know, there's a step higher than that maybe, which is you acknowledge me and you said I'm willing to hear more if you want to tell me, okay? Or you said you're not crazy for having a feeling about what you're going through. Again, this is just being really human. Now, we also looked at videotapes to see how often these things are happening, and it turns out that what patients are looking for happens 85% of the time. That's great. The shared feeling or experience happens 2% of the time. That feels real to me. I could imagine that being real. Like somebody tells you something, you're like, yeah, that happened to my sister, right? That kind of thing. That feels about right 2% of the time. If I were expected to do that every single patient, I wouldn't feel authentic and I would feel exhausted, right? Now, 2 and 85 don't add up to 100%. So there are 13% of the time where the doctor, these were doctor-patient encounters, where 13% of the time the doctor either ignored what the patient said when they said something was really hard or really great, or they were really emotional about something. They either ignored it or they basically said, that's not happening. Okay? Now, I developed something about 20 years ago called the Communication Assessment Tool. It was funded by the American Board of Medical Specialties. And it's a way for patients to basically let doctors and other healthcare professionals know whether or not important things are happening in the encounter. I'm going to show you here, these are the tasks that we're asking them to look at, ranging from greeted me in a way that made me feel comfortable, down through let me talk without interruptions, all the way to showed care and concern and spent the right amount of time with me. This is some data that I promised to show you. These curves, I won't spend a lot of time on this, But the red curve here is, the scale goes poor, fair, good, very good, excellent. The red curve is poor, fair, good, and very good. The blue curve is excellent. And on the left-hand side, it's yes and no. And you can see that excellent maps onto yes and everything else maps onto no. So even when people are saying very good, they're just politely saying no. Here's data. These are doctors that the American Board of Medical Specialties picked to try this out when we first did it. And just pay attention to what's bold here. So the things that scored low were check to be sure I understood everything, encourage me to ask questions, and involve me in decisions as much as I wanted. Watch this next one. So this is a medical group. This is 20,000 patients. The lowest things here, encourage me to ask questions, involve me in decisions as much as I wanted. This is hospitalists. You can see the scores are lower because they don't have a relationship with the patients. They're usually just coming into the hospital rooms and meeting the patient for the first time. What's lowest? Greeted me in a way that made me feel comfortable, encouraged me to ask questions, involved me in decisions. Emergency room teams, same things are low. Family medicine residents, same things are low. A global view, we did this in 20 countries, same things are low. So this is what I call the en medio de los otros test. What hits you between the eyes? Yeah? You don't have to have a PhD in statistics to know that these are the problematic things. And if you think about it, those PCC indicators encourage me to ask questions, involve me in decisions as much as I wanted, right? They're right there. But you have to be careful of what I call passing the test but failing the patient, okay? This is one of the best doctors I know. This is from one of my early research tapes. And she is literally walking out the door. The door's open and she's leaving when she says to the patient, do you have any questions? Okay, that's not encouraging a patient to ask questions. That's saying, I did it. I asked if they had questions, but the patient doesn't feel like it encouraged them to ask questions, right? So the last thing, we only have 2 minutes left here. The last thing I want to show you is this sense of what matters to patients from a different perspective, okay? So the Institute of Medicine asked, they put out what's the 6 domains of quality. You see them here. We asked patients what they think quality is because the Institute of Medicine didn't ever ask them. And they said, yeah, safety, effectiveness, patient-centeredness, communication, and cleanliness are quality through the eyes of patients. We asked patients what they think safety is. Most people that work in healthcare focus on preventing physical harm for all sorts of good reasons. That's not wrong. But patients said it's also preventing emotional harm and making sure I feel like I'm in a safe environment in terms of cleanliness and security. Equity, there's a definition of, or there are lots of official definitions of equity, like everyone has a fair and just opportunity to attain their highest level of health. Patients just want you to see me as me, not a type, okay? And I'm gonna wrap up here with an idea that brings this all together, I think. Peter works with a fellow named Paul Batalden, who once said, every system is perfectly designed to get the results it gets. That is true, okay? But if every system's perfectly designed to get the results it gets, we've got to change the system because the results aren't good. They're not good enough, and we've established that today, okay? And the way to change the system is to move beyond silos, okay? These silos of this is experience work, this is quality work, this is safety work, this is equity work. That does not work. It's making it too hard for people to do their jobs. We need to find the overlap between these things and prioritize the overlap And that will make it easier to elevate all of them at the same time. That's what I mean by one big dot. I got this idea when I was going around the United States talking with leaders of healthcare systems, and they kept saying things like, oh, we get it. We need to connect the dots between experience and quality and safety and equity. And I was like, yeah, sort of. But you're missing the point. It's all one big dot. They're not the same thing. I'm not naive. They have different measures. They have different levers. But they all interrelate. I made a giant spreadsheet of every publicly reported measure I could find for quality and safety. They're all experience measures too. If I get readmitted to the hospital, I had a bad experience. If I have an infection, I had a bad experience. Okay? All of these things are, Peter said earlier today, everything is safety, right? Yes, everything is quality. Yes, everything is experience, right? All of this. And that's how we have to start thinking. We have to think differently. We have to change the system. And I have to stop pushing reverse. And thank you very much for your attention.